let's get after it. Let's do it. I told y'all, this one has my bad picture in it, so I warn you. So you can look away for those of you with weak stomachs. If you have a weak stomach, you shouldn't be in here, but there's a chance you're here. Huh?
Yes.
Let's do it. Okay, what we're going to be looking at is how you're going to be able to, or learn to balance the need to treat a patient on scene versus transporting them immediately. Right? We're going to look at determining how severe a patient is, how bad they are based on their signs and symptoms, and then making the appropriate transport destination. Now in this area, that's going to be a little bit more important probably because we don't have a whole lot of choices, but we certainly don't have a trauma center. Whereas if you're in downtown Birmingham, you know, you kind of, it's not a big question there either. How to select critical interventions to implement at the scene for a multi-trauma patient. Multi-trauma patient, multi-system trauma patient is somebody that has more than just one injury, where you have reason to suspect that they may have multiple injuries that are throughout the body. We're going to look at the trauma score too. I already did that. Okay, multi-system trauma. All right, you're looking at this guy. You see his injuries. You drive up, and there's this guy. What systems do you think are involved here? What are you concerned about based on what you see? His leg here, because he's bleeding. Okay, so you could have some significant blood loss, right? What else? Possible, or he might just his hips, the way his hips are shaped. It could mean something, could not. What did y'all say?
Oh, if he's alive.
Why would you suspect a spinal injury? Possible. Anytime a patient's unconscious and you don't know how they got there, outside of some reason to believe otherwise, you're going to treat it like it's a spinal injury. Because you don't know. He could have been hit by a car and thrown 50 feet. You know, he could have fallen out of a tree. Of course, you know, I don't know where that tree would have been. But you don't really know what happened here. This could actually have been a gunshot wound. So you're probably going to spinal mobilize. So what else do you see about him then? Some road rash, yeah. He might have just wiped his nose too, who knows. So what else? One significant thing, the first thing I'm going to notice. Yeah, he's got definitely an altered mental status here. Anybody that's unconscious or has an altered mental status, you're going to assume the worst about them because altered mental status is something that can kill you. So let's see here. Multisystem trauma is going to be a patient with one or more injuries serious enough to affect more than one body system. For instance, they've lost, 3 pints of blood. Is that going to be a multi-system problem? Yeah, if they don't have enough blood, they have a lot of other problems going on, right? They're poorly perfused, the heart's not working, the respiratory system's not going to work well, certainly. Okay, when we're trying to determine the patient's severity, we've got criteria we're going to look at. The physiologic criteria, anatomic criteria, mechanism of injury. Is that all I've got on this page? Yeah, so these are different things that we're going to look at. Anatomic criteria, any idea about what that is? Because y'all read your books, right? The what? Yeah, problems with their anatomy. You know, if they've got angulated fractures, that sort of thing. What about physiological? That could be some other things going on. It could be altered mental status. It could be a brain injury. Mechanism of injury, we know what that is, right? But there's some other things that we're going to factor in, such as age. The severity of a patient that's 85 is going to be different than, a severity of a patient that's 25 that's sustained the same injury. Why do you think that is?
An older person can't compensate as good.
They don't compensate well at all because their body systems, certainly all their body systems are weaker. They also may have other mitigating problems. They may have heart disease on top of that. They may be diabetic. They may have COPD. So they may have other underlying issues that make it that much worse. So usually if a patient's over the age of 55, we just about double the mechanism of injury for them because their outcome is about twice as bad as a younger person. And then also we want to look at a child. little kids, pediatric patients, also frequently have a worse outcome because when you're looking at mechanism of injury and exchange of energy, then they oftentimes have a worse outcome. So you want to take a lot of things into consideration. If they just have a broken arm, but their head bounced along, the cement for a few feet, then you may have a variety of things going on there. The physiological criteria is going to be their function, their mental status. Now we talked about the Glasgow Coma Scale. If they've got a Glasgow score of less than 14, that would be 13, right? That means they're missing a couple of points along the way. You're looking at an altered mental status of some sort. So if they've got less than 14, you're looking at a head injury. We usually say less than 8 intubate. So if they've got less than 8, they're extremely critical. And at the upper levels, we'll usually intubate them. If their blood pressure is very low, if they're obviously shocky, if they've got a systolic blood pressure of less than 90, then you're looking at some type of internal bleeding, or it could be external bleeding if they've lost a lot of blood. But outside of seeing blood loss, if they've got a low blood pressure, there's a good chance you've got some internal bleeding going on. These are physiological issues. If their respiratory rate is very slow, remember when we were talking about pressure on the brain stem, the respiratory center? If you've got pressure on there, you're usually going to see slow, possibly irregular respiratory patterns. The upper levels, you'll learn a whole bunch of different respiratory patterns, but specifically when you've got pressure on the brain stem, you're looking at irregular respirations in some form or another. Remember early in the semester I told you that most of the time we breathe fairly regularly. Our pulses, if we took a pulse of everybody in the room, probably a third of you are going to have some type of irregular pulse. But if we counted and watched your respirations, most of you are going to be breathing very rhythmically, in and out. Some faster, some slower, but it's going to be very regular. When you've got pressure on the brain stem or some other neurological issues, then to cause irregular breathing, that's going to be different. So you're looking at a brain issue usually when you have irregular respirations. Look for a head injury. Also, you have a slow respiratory rate in late signs of shock. We don't usually see late shock unless it's been a very severe injury. If they have an abnormally high respiratory rate, we're also looking at shock. Remember the signs and symptoms of shock? I don't think I drew my little thing. I'm going to draw it right now because I love to draw. Did y'all ever see, does my drawing show up on here when I post it? Nobody's looked. Okay. Here is if y'all like to draw, this is something you need to draw in your little books. Okay, if a patient is in shock, early stages of shock, compensated, moving to decompensated, what does the heart rate do? Hello? It increases. They become tachycardic. What does the blood pressure do in shock? It goes down. That's right. What's the respiratory rate? It's going to increase. Shock, they don't have enough blood. Their blood pressure's low. They have to, the heart rate goes up, the blood pressure starts to drop because they've lost blood, but the respirations usually go up because they're trying to circulate more oxygen, right? Okay, intracranial pressure. This is a head injury. What happens in a head injury to the heart rate? Okay, this is something called Cushing's triad. I call it Cushing's triad because triad has what? 3 things. Sometimes you'll see it written as Cushing's reflex. Yeah. So Cushing's, there's 3 parts to Cushing's. Cushing's indicates intracranial pressure. So when you're trying to determine if your patient has a head injury, you're going to be looking for signs of the Cushing's triad. Cushing's triad, the heart rate does what? Goes down. The blood pressure goes up. And when they're really bad, the respirations get real irregular. This is Cushing's triad. It's a sign of increasing intracranial pressure. Why would the blood pressure go up? Think. Kind of work through your brain. We've got a head injury. You've got swelling in the brain. Why would the blood pressure go up? You got so much pressure in the brain, the blood pressure has to go up to perfuse the brain. It just can't get through. It's too squeezed tight in there. So the blood pressure is going to go up to perfuse the brain. Why does the heart rate go down? Do what? Well, there's really not enough blood in the brain to affect that, believe it or not, but that reminds me to tell you all something else. What happens with the heart rate, think about this. When the heart's going like this, how much blood pressure can it get? Not so much. So in order to get that kind of blood pressure, it's got to allow the heart to fill, and it's going to get a really powerful contraction there. In order for that to occur, it's going to have to slow. So the heart rate goes down, so it can go whoom, whoom, like that. And the blood pressure is going up to perfuse the brain. But as the brain swells, and we get, what do we call that, where the brain goes down? The herniation, brain herniation. When you see brain herniation, you get pressure on the respiratory center there, then you're going to get irregular respirations. So if you've got a patient with irregular respirations, you know there's something neurological going on there. And this is very frequently it. What did you say? And I said, remind me to tell something. See, I already forgot.
You said there's not enough blood in the brain.
Yeah, thank you. This is important. You can't lose enough blood in your brain to make you shocky. There's just, outside of, severing an artery here, which is not in the brain, there's just not enough space up there to allow that kind of bleeding. So if you've got a patient that's showing signs of shock, remember, low blood pressure, tachycardia, if they're showing signs of shock, it's because they've lost blood. It's not because of this, okay? So if you have a patient whose vital signs are, say, let's see, respirations, 14, blood pressure, 106 over, 72, and what's the other one? Pulse is 118. You look like we're getting shocky, right?
Yeah.
Kind of moving that direction. This does not look like a head injury, which would look like you may have irregular respirations, but you're talking about a blood pressure of 180 over 110 and a pulse of 52. So you can see the difference in these patterns, right? So if you've got a patient that's presenting with shock, they could have a head injury, but they're bleeding somewhere too, so you better keep looking. Does that make sense? Cushing's, you'll need to know that. Because on testing, on National Registry, you're going to get a set of vital signs, and they're going to say which one of these presents like Cushing's or indicates a increasing intracranial pressure. And you'll have to be able to look at the vital signs. They may even ask to determine if you can understand why those vital signs present like that. So make sure you understand that. Okay, high respiratory rate, shock, right? Low respiratory rate, irregular respiratory rate, what? Head injury. High blood pressure, head injury. Particularly, we'll learn a little bit later about our stroke patients. If you've got a patient that's had a stroke, where they've got bleeding in the brain, what's their blood pressure going to be like? It's going to be off the charts. It's usually very high. Anatomic criteria. This is going to be a body part where there's been some type of injury. maybe an injury to the head, the chest, could be multiple injuries of musculoskeletal type, amputations, mangled extremities, deformities, that kind of thing. Pelvic injuries. We were talking about shock a few minutes ago. Remember, how much blood can you lose in a broken pelvis? Lots, you know, up to 3 liters, I think, wasn't it? Yeah. How much can you lose in a femur fracture? Yeah, you can easily lose 1 liter per femur fracture. Yeah, you can lose a lot. Mechanism of injury. Make sure you determine what the mechanism of injury is. If you don't see injuries, if you don't notice that they have altered mental status, the blood pressure is not up or down or whatever, outside of that, bottom line, you're going to look at what? Mechanism of injury. Falls are one of the most common severe mechanism of injuries. High velocity auto crash, automobile, pedestrian, those are almost never good. Motorcycle crashes, well, those don't usually have a good outcome. We think of them as really good runs, though. Not really. That was rude. Sorry. It goes to my picture at the end. Managing the multi-system trauma patient. You got to expect the worst and treat for it. Okay, if you get that call for out on the interstate and they say there's multiple patients, you need to start working through in your mind, along with your partner, how you're going to manage this. You both can't jump out of the truck and run to the same patient, right? You got to split that thing up. You may have to do some triage. We're going to look at triage towards the end of the semester, where you decide who you're going to treat and who you're going to not. You know, if you've got 15 patients out there and it's you and your partner, and one of those guys is in cardiac arrest, are you going to do CPR? Okay, so you're going to let 5 people die so you can do CPR on the dead guy?
No.
Yeah, no, you get the idea. So triage, actually, you're providing the most care to the most people. That's what you're trying to do. The best outcome for as many people as possible. If you devote all your resources to the dead guy, he ain't coming back, particularly if he's a dead guy from a trauma. Those guys don't come back. But if you have allowed somebody else to die when they were salvageable, then you'll feel really bad about that. But en route, you need to start talking through who's going to do what. Like, one of the first things you need to do when you roll up is determine what other resources you're going to need, right? Remember the parts of the scene size up? What are those? All right, certainly BSI, scene safe, and then what? Yeah, we've really learned those sheets, right? Mechanism of injury, number of patients, call for additional resources, consider spinal mobilization. Everybody look on your sheets. I'm not going to tell you. Huh? Patient priority is down. That's going to be in your initial assessment. Transport priority is only after you assess a patient. So we don't do that till later. Look on your sheet. Somebody look at it. You won't remember it if I tell you. You don't remember it anyway. Do what?
The motor century.
Nope, but that's once we touch a patient. As you drive up, you're doing your scene size up, remember? This is part of your scene size up.
Yeah, it says take standard precautions, mechanism of injury.
Mechanism of injury.
Number of patients.
Number of patients.
Any additional resources.
Additional resources.
Consider spinal mobilization.
Did we say 4 or 5?
But,
What's above? The first one says BSI.
yeah, it says check scene safety, take standard precautions.
That's above that, right?
That was the first.
It's above scene size up.
That's the first book.
Please determine scene, situational state, mechanism of injury, number of patients, assistance in spinalization.
Yeah, patient verbalizes BSIs at the very top. Then, yeah.
Not all five in that sense.
Yeah. Okay. That's good. So you have to go through all of those things before you ever touch a patient, before you start triaging. So you're going to be considering those as you're driving up on the scene. Scene safety is important. If you're looking at a wreck with 15 people out on the interstate, you got 5 or 6 cars involved, can you think of any scene safety issues?
Like, are they
bystanders, other vehicles zooming by, yeah, there are a lot of things that are a problem. And different trauma scenarios present different dangers to you, right? You know, somebody with a knife doesn't scare me nearly as bad as somebody with a gun. Being out on the interstate is different than being, you know, up on my street where nobody ever drives through. So, according to what's going on, you're going to have different dangers. So you have to be constantly thinking. Multisystem trauma. You're going to have to follow the priorities of your primary assessment. And they are what? A, B, C. That's right. What are those parts? What are the first three parts of your primary assessment?
Life-threatening injuries.
Mental status. Before that. Remember, there are three things, and then three things. General impression, chief complaint, mechanism of injury. And now we move into A, B, C, and then transport decision. That's right. Okay.
If you're, like, you get to a wreck and, like, there's a dead person in the middle of the road, but there's people on the side of the road that are not dead, that could be dead. What do you, like, what's first?
They're not dead, but could be dead.
Like, they're serious injuries.
That's a triage situation. The dead guy's dead. You're going to go take care of the people that you can save.
The dead guy in the middle caused another accident.
Oh, I'm going to drag him off the edge.
Okay.
Unless, you know, hopefully somebody's going to stop the interstate. But yeah, you'll have to move him. I mean, you hate for him to continually be run over.
Yeah, I was just
Never
like
good.
goes first.
Yeah. I'm getting somebody else to drag the dead guy. You're going to worry about, yeah. That sounded really callous. I'm sorry. That's really Brenda says what to treat on scene and what needs definitive care. What will we treat on scene? A, B, C. Anything that'll kill your patient right away. Everything else, all that splinting stuff, you're going to do en route. They need definitive care. This is where we say we've got that 10 minutes on scene, and it moves very, very fast. You're going to stabilize them. You're going to do your ABCs, your rapid trauma assessment, put them on a long spine board, everything else you're going to do in the truck. But like we said before, if there's a really grotesque injury, you're going to have to really fight with yourself to, like, worry about breathing when you want to really look at that nasty old ankle or whatever it is. So you have to force yourself not to do that. Call the hospital as soon as possible. If particularly here, if they have to call staff in or call in a surgeon or anything like that, the more lead time you give them, the better care your patient's going to get. So frequently, as soon as you arrive on scene and you see you've got whatever it is, as soon as you have a minimum assessment, you might go ahead and call them and say, we're on the interstate and we've got 6 or 7 really bad patients, so we're going to be bringing some patients to you. And that's all you need to tell them until you do some assessments. Maybe you get en route, then you call them and say, we're 10 minutes out. But I would certainly call them as soon as you have something definitive, call them again with specific patient information. Because a large hospital, if you go up to a trauma center, you go to UAB, they probably don't want to hear from you. Just, you know, let them know we're coming. Because they'll have all the staff there needed. Whereas at the smaller hospital, they need as much heads up as possible. With multi-system trauma, getting the vital signs is not nearly as important as beginning to treat your patient and then alerting the hospital. If it means postponing getting your vital signs in order to alert the hospital, you should probably go ahead and do that. Limit scene treatment to suctioning. All these are going to be your ABCs. Putting in an oral airway if needed. Make sure your patient's airway is patent. Providing oxygen, controlling bleeding, immobilization. That's really just about it. How are you going to immobilize, or how are you going to splint these patients? Long spine board. What do all these have in common? Possible life-threatening, and they're all on the top part of the sheet. You know, they're all in your ABCs, except for spinal mobilization.
Has there ever been like an incident where like you don't even have time to do anything on the thing, you have to do it all at the same time?
Yeah, if you got somebody that's just got a gusher, they're just bleeding all over the place, then yeah, you're probably gonna.
Just like get in and go it
Yeah, but those are things you're gonna make that decision about, you know, depending on how bad it is, and can you explain why you did it. Expect the unexpected. With multi-system trauma, all bets are off, and you're going to have to be very adaptable. You're going to have to make decisions. I can give you guidelines, but you're going to be making these decisions. You're going to have to do whatever's necessary to ensure that patient has a patent airway. Now, that doesn't mean, do an emergency crike. That's not what I'm talking about here, okay? So I don't want to hear that from you. I don't want to read about it in the paper. But if you suspect they've got a spinal injury and you can't secure the airway, guess what? They're getting a head tilt chin lift, if that's what it takes, because that's most important. Perform whatever type of move is necessary. Remember I was talking about if your patient's stable enough, take the time to put them in a KED. They're not breathing or they're squirting blood all over the place. They got a severely altered mental status. You're going to snatch them and you're going to put them right on that long spine board and be as quick as possible about it. So sometimes you have to do an emergency move. If part of a patient's body is not accessible, then you're just going to have to assess and treat the part that you can reach. If their legs are trapped, from the hips down underneath the dashboard, you can't get to them, guess what? You can't get to them. So you do the best you can with what you got. Trauma scoring, there's a lot of different trauma scores out there. There's one that they've kind of settled on now, a trauma score. It's different than the Glasgow Coma Scale, but it usually takes the Glasgow along with some other factors or criteria. And it's going to give a number. They have a pediatric scale as well as the adult scale, and it's pretty objective. I know the state of Florida had a really good trauma scoring system where depending on, like if they had multiple peripheral trauma, like they had 2 broken arms and a broken leg, then you give them more points, and if they just had a broken leg. So that you can quantify that objectively more so than not. But one thing that all these scales will allow you is for you, the provider, to make a choice. You may add up the numbers and it doesn't look bad, but you look at your patient and you go, whoa, they look really bad, then that's going to override everything else and go ahead and send them to a trauma center. We talked about that early on. If you look at them and they look really bad, they probably are really bad. Even if you palpate, you determine everything, and you can't come up for any reason for them looking really bad, well, then you just assume they're really bad. Revised trauma score. This is going to use the Glasgow Coma Scale, their blood pressure, and their respiratory rate. Now, I can't tell you that you won't see this on National Registry. I haven't heard of it being on registry before, but it could be. I'm not going to ask you a question about this, but it's not going to hurt you to learn it. The revised trauma score is going to take the Glasgow Coma Scale, their blood pressure, and their respiratory rate. Do not let getting a trauma score or even a Glasgow Coma Scale interfere with care of your patient. This is just a sample of the Glasgow Coma Scale along with the other 2 criteria. So that you can see, like the blood pressure, if the blood pressure is less than 90, greater than 90, they get full points. Because 90 and above is a blood pressure within normal limits. When it hovers around 90, you get a little bit nervous, but 90 is the cutoff. Below 90, it goes down from there. Respiratory rate, if they're breathing between 10 and 29, they're breathing okay. Don't have to worry about them. Less than that, it gets pretty bad. Let's see. Multisystem trauma is a serious condition in which 2 or more major body systems are affected. You need to triage appropriately based on your presentation. We'll look at that later in the semester. Transport to the proper destination. The CDC, you know what that is, right? Center for Disease Control, has guidelines about the trauma triage thing. This is what I told you is fairly new. The last couple of years they've come out with this. Some systems are using it, some are not. They want everybody to use it. It's called the Revised Trauma Score. Remember, primary assessment should tell you pretty much all you need to know about your patient. Limit scene time to life-threatening conditions. The golden hour, which you'll hear about, starts from the time of the injury to the time the patient's in the OR. If from the time of the injury they can hit the OR within 60 minutes, they have a much better outcome. So of that time, you've got to figure recognition. Somebody's got to call 911. You've got to get there. You've got to package and transport. They have to be evaluated, and you got to get them to the hospital. They got to be evaluated there. They got to get the OR team set up. So there's not much time there. So we really have to limit our time on scene for the patient to have the best chance of survival. Look at their physiological criteria, anatomic, and the mechanism of injury to determine transport destination. You're looking at mechanism of injury. Do they have the potential of turning bad on you? And a lot of them do. And that's what you're really looking for. You're projecting, if this runs its full course, how bad can this get? Okay. A patient was involved in a car crash with significant intrusion into the area where the patient was sitting. Remember we talked about that? If there's compartment intrusion, usually of 12 inches or more, you're looking at some serious intrusion. The patient is alert and complains of pain in the ribs. The pulse is 96 and regular. Is that within normal limits? Yes. Respiration's 30 and adequate. 30 is a little fast, but could that be normal? Are they scared to death? It could be. And also, you got to watch because it could be on the high side there. Blood pressure 100 over 62. Is that within normal limits? You know, in black and white, 110 is within normal limits. That's a great blood pressure. But is this a patient that normally has 160 over 92? Could be. Pupils are equal and reactive. Skin is cool and dry. Cool's probably not so good. The what? They could have. Is it still running and I'm standing outside? If they're cool out here today, I am worried about it. Okay, your partner says the patient is stable and could easily be transported to the community hospital. You think the patient should be transported to the trauma center. How would you justify your decision to your partner? Mechanism of injury, absolutely. Even though if you look at all these vital signs, they really are explainable. Is it raining again? So based on what you see right there, there's nothing that's a really big red flag. But mechanism of injury is. And if you don't move on this patient, 15 minutes from now, you could have a patient that's crashing on you, and you're taking your time with them, or you've taken them to the wrong place. Look at the following photo and determine which systems would most likely be injured. Now, if you have a weak stomach, look away. Looking to see who looks away. This is an actual photo that a friend emailed to me about 20 years ago when we lived in California. This guy lived.
I would just rather die.
Do what?
I would just rather die. What's that in his stomach?
Telephone pole?
That's the other end of that stick.
It was in his stomach.
In his stomach?
Yeah,
He's
this
just
area
cutting
right
something
here.
just
Or
like
not
that.
at work.
It's
I
just
guess
like
it technically could be in his
this.
stomach.
Well, he's a big guy anyway. I can't tell what's under here.
That's the other end of the stick.
Yeah.
Or the log, whatever. It looks like a tree he was cutting.
Goes on.
Oh, that is the
It's
law.
got a
This is the law.
See,
Yeah.
that is the law, 'cause you,
Yeah, due to
Yeah.
the coloring in his
It's his
legs,
skin's
he's
pulled
going to
back.
really
Oh yeah, he's not doing so good here. But you can see somebody had to cut this thing off, right?
Yeah, she doesn't look happy in the background.
No, you're just hoping he was, unconscious the whole time.
oh,
This
he's
guy
got a
survived.
justice system.
Now, how long he survived, I don't know. But
Was the
What was the
Huh? I think it was a motorcycle, and he hit something.
How does he like these? That's got a screw on
He-
his pelvis. And like,
Is that your jacket?
It is.
Yeah. We knew somebody would come for it.
Thank you.
Alrighty, y'all done, I guess, huh?
Oh my gosh.
Yeah, so anyway, that's really gross, isn't it? Did that gross you out?
That's actually not that, I was expecting you to way worse.
Did you gonna be real bloody?
I thought it would be real bad.
Oh, so you're disappointed? Is that what you're saying?
It's really interesting. Did he I wonder if he lost his that leg.